Well, thank you for agreeing to do this interview. Would you mind letting everyone know who you are and what you do?
So I'm Andrea Doud. I'm one of the pediatric surgeons at University of Kentucky Children's Hospital. I also have a strong interest in trauma surgery and recently did a fellowship in adult trauma. So I'm going to be spanning pediatric and adult trauma patient care.
Wow, that's pretty impressive. That's a lot.
It's a lot.
Kids and adults.
Yeah.
Well, you seem like the right person to talk to about this. And now you don't routinely give whole blood to pediatrics in your practice. Is that correct?
No, it's definitely something that we are interested in, and we've talked about. Our current massive transfusion protocol involves component separation, but I've certainly talked to Dr. Schmuckler about changing that to whole blood, but it is it's something that isn't well studied in pediatrics.
Okay. Well, although you might not be the expert in whole blood, you're certainly the expert in pediatric trauma, I'm sure, so you can teach us a thing or two about that. And you know about just blood administration in general. So with kids, there's like this fear, right, of treating sick and injured kids. There's a saying that kids are not little adults, and then some people say, well, kids kind of are like little adults, so let's not scare everybody. Let's kind of just take a similar approach and just understand some differences, okay? Now, what are the differences in recognizing shock in kids?
So kids have an amazing ability to compensate. And so children can maintain blood pressure for a really, really long time. We call it falling off of the cliff. They'll be really, really tachycardic, but everyone's like, oh, they're normotensive, but then they just plummet. And so you should never underestimate tachycardia, particularly in a child. Some of the more subtle signs that I'm sure are similar in adults, but more pronounced in kids, and especially difficult when you can't rely on blood pressure as much. So cool, clammy hands, lethargy. Kids very often have traumatic brain injury, so it's easy to assume someone has a head injury because of lethargy, but oftentimes it's hemorrhagic shock. Thready distal pulses or just central pulses only, decreased cap refill, I think I said cool, clammy hands, diaphoresis. Those are all common signs of hemorrhagic shock in a child.
Okay. I think we've included altered mental status, prolonged capillary refill, hypoxia, and so it seems like rely less on the blood pressure. Mm-hmm. If they are hypotensive, that's probably a late sign.
Correct.
Correct?
Yeah, hypotension is a very late sign. Increased respiratory rate as well is another sign. They already have a really high metabolic demand, and when they're bleeding, the metabolic demand goes up more so than in adults.
Oh, very interesting. Now we don't want to unnecessarily transfuse kids, and since we're not accustomed to seeing a lot of bleeding in children like we are adults, our rate of over triage might be a little higher, but also don't want to discourage our folks from giving blood if they think someone needs blood. So how do you think we can avoid unnecessarily transfusing them? And would there be any harm, do you think, in transfusing them?
So I think the bigger harm would be if someone's bleeding to death to not give them blood. Transfusion reactions are certainly something to consider. The most common transfusion reaction would just be like a febrile or allergic reaction, in which case, you stop the transfusion, you give Benadryl, Tylenol, Pepcid. but I think particularly in neonates, there's more concern about hyperkalemia and hypothermia from the blood and things like that. But I think, it's pretty rare that you guys are going to be treating neonates.
Yeah.
And so once you get to, toddlers, school-age children, I think that those risks are less and more likely to be just a simple febrile reaction. So, if you really think that someone is hypotensive or in hemorrhagic shock, I think the safer thing would be to start blood. And signs of that, like we talked about previously, would be, cool, clammy hands, hypoxia, increased respiratory rate, tachycardia, or just reports of a lot of blood loss on the scene, a big distended abdomen, or bruising of the abdomen, decreased, breath sounds indicating some sort of hemorrhagic hemothorax or something.
Perfect. I know that was not a question that I marked, so sorry about that.
Oh, that's okay.
I'll be more careful.
No, you're fine. Feel free to delete anything that sounds stupid.
Okay, no, that was great. So you marked number 3, the push-pull method for administering blood. Now, we try to simplify our blood logistics as much as possible to encourage people to use it. The more complicated it is, the less likely people are going to go through the whole process of giving it. So we want to use a simple push-pull of pulling it up from the line in the bag, clamping off, and then administering. And we're going to do that generally if they're less than 6 and greater than 2 for the push-pull. Did you want to comment any on that?
Just that it's a much more efficient method to get blood more quickly into a smaller human that you can't get a large IV or even a large IO in. So that's why we tend to recommend that.
Okay, perfect. And just for everybody listening, I think a unit of whole blood does come with some air in it. So that is something we have to be careful for. Less concerning for adults, but probably more concerning getting air in a smaller person. Now, why, I think you or someone else mentioned that we probably should not give calcium chloride to children. Why is that not recommended?
So it's a vesicant, and so it can cause tissue necrosis if it extravasates, which would be true in an adult as well, but pediatric IVs, as I'm sure you've experienced, are much more likely to blow or extravasate, and so it's been taken out of the PALS algorithm and not recommended. And something to bring up when you talk about blood transfusion, because of course the citrate in the blood can make kids hypocalcemic,
Yep.
And they may need calcium, but the preferred would be like calcium gluconate or something.
Okay, perfect. Which some places may carry, we have 4 different services rolling this out. We only carry calcium chloride just for practical logistical reasons. You need 3 gluconates for 1 chloride, so it's just much more efficient, but we do got to be very careful, make sure we got a big fat IV that's patent, flowing well in adults. But in kids, just the risk is not worth the reward or greater than the reward.
Yeah, typically. I think everything's a judgment, a clinical judgment scenario. And so, you have to use what you know and do the best thing for the child when you're with them.
Perfect. Well, that makes a lot of sense. So, based on what you know about blood, do you think low titer whole blood is safe for pediatric patients? And are there any particular considerations with the age or the weight of the child?
So I think it's safe. As with anything, there's less literature for peds than in adults. There's lower sample sizes. There's I think about 7 studies about whole blood use in pediatrics, so it does exist. In several of the studies, they went as low as 1 year of age. And most of them included a 10 kilogram like lower limit, but there were 2 that had no lower weight limit, and there were no adverse events, worry about hemolytic reactions, and blood transfusion acute reactions in particular, and there were no reported reactions or adverse events in really any of the studies. So
was this low titer O positive?
I think so. I'd have to double check.
I think most of them, if it's whole blood, that's what they're given.
Yeah.
It's hard to get the O negative.
Yeah. So, that's what obviously the concern is. But in the studies that I saw, it's safe.
Perfect. Sounds good. Now, I think we've talked about the physiology of hemorrhagic shock in children, but do you see this potentially changing outcomes for pediatric trauma patients? Because you see a lot of them come in getting a lot of isotonic solutions when they're bleeding. So do you think you're going to see different physiology? Is it going to stabilize them for surgery down the line or anything like that?
I think so. It gives you the opportunity for balanced resuscitation early. So I think it would be rare that you guys would be able to carry platelets and FFP and red cells. And the other thing with kids is they are particularly sensitive to volume overload. So they're smaller. And so whole blood allows you to give all of those components in a smaller amount of volume with fewer additives. And so if you're giving a balanced resuscitation with coagulation factors and platelets, you are less likely to be coagulopathic in the OR or in general, and hopefully able to stop the bleeding, which is the main thing that we want to do is stop the bleed sooner in the course. Rather than once they're coagulopathic, even in the OR, if you stop the main source of bleeding, everything's oozy. And so if you're able to maintain that coagulation status, I don't think that the studies have gone that many steps ahead, but it just makes sense that you'd be hopefully avoiding that lethal triad.
Yep. I think when we went to me, Dr. Bernard, and Eddie Cruz from Lexington Fire went to San Antonio to their whole blood academy, and their surgeon said, yeah, it makes surgery so much better because the hemodynamics are optimized, we can get straight to it, and they said it just makes everything a little bit better.
Yeah, because, if they've come in, just with red cells because that's what's available, they've bled out platelets and coagulation factors. They've used up platelets and coagulation factors, their body intrinsically trying to stop the bleeding.
Yep.
And so if we are able to give them all of that at the same time, then we can hopefully prevent that. And that's one of the worst things in the OR is the spleen's bleeding, you get the spleen out, and then everything else is just oozing.
Oh, yeah. Yeah, and I mean, we honestly, it's, and the volume of a whole blood bag is, I think, even more than if we were to give 2 units of packed cells, 500 mLs versus low 200 and something a piece for like red cells. And honestly, we could have went that route. It probably would have been easier to get it, but to administer it, it makes it much more complicated. It's just so much logistically easier, one unit, one line, straight through one warmer, just the logistics are so much easier.
Yes.
So, now we talked about the volume. We've discussed this previously, I think. Should we have, and maybe this could be a two-parter, but should we have weight-based guidelines for initiating low titer O whole blood in pediatric cases? And if so, at what age does that become more of a give a 200, 250 ml aliquot, see how they respond, and give the rest if needed?
Yeah, so I think in the young ones you have to be really careful. A typical transfusion in a kid would be, 10 to 15 milliliters per kilogram. Yeah, I think that that's a really interesting question because I think we don't know for sure, but most people I think would say around 15 or 16 years of age, or when you look at them and they look like an adult, would be what I would say. Even a little younger than that, 13, 14, they're certainly acting more like adults. But here, our 16-year-olds go to the adult side of the house. So certainly they are treated like adults and do well. I'd say, yeah, for once you get to, a 250 bolus, I think is, in an infant or a toddler, I think it'd be more important to have an idea of their weight and give them a volume based on that. Once they get to be sort of, school age, 9, 10, 11, I think it'd be okay to give like a 250 aliquot and see what you get.
Perfect. And that's something for us to just consider. Hey, if they're like a bigger kid, maybe you don't have to be as precise, but you would still want to not give the whole thing right off the bat. Mm-hmm. Just give an aliquot, see how they respond, and then give more.
Right.
Sometimes we may not know their age.
Right.
Too, we're going to have to estimate and be like, they look about like this.
Yeah.
And calculating someone's weight.
Yeah, it's nearly
not precise.
Impossible, yeah.
So we're going to be like, I'm going to give a little, see how they do.
Yeah. Yeah, I think so. It's got to be so hard in the field when you don't know. Even when they show up in RED, we have the Broslow tape, but a lot of times we don't have time to just all separate from the bed and weigh them. I can't, out in the field, it's got to be so difficult. And you see kids as such a small number of everything else you see.
Everything. And that's why we try to simplify things. And as much as possible, as long as it's safe, we try to say, treat kids like little adults. Just the sizes of things are different, the physiology's a little different, and the dosages are different. But we've got apps for that. And we've got the tape, we can figure out roughly what their age and weight should be, and then the app will tell us exactly everything else for blood as well. So it should tell us the volumes that child needs. And I don't want, I think I told Dr. Davidson this earlier, when we're talking about shock index, I don't want people doing complex math. If the heart rate's greater than the systolic, the shock index is pretty high. So, that's a high shock index.
Yeah.
So.
And it is hard to know in a kid sometimes, like a baby too, and they're screaming and crying, their heart rate can shoot up pretty fast. So I think it's important to recognize if they're screaming and crying, but they're warm and they're not, and they've got strong pulses and they're pink, then it's probably that they're upset and not in shock. If they're kind of lethargic and their heart rate's high or they're cool and clammy, then that's a different kid.
Yeah, their heart rate could shoot up pretty high. The rule of thumb I tell people is generally the SA node can go up to around 220 minus the age. Mm-hmm. So they can be sinus tach. For kids, we see a heart rate of 200, and we're like, that's SVT. Not necessarily. That could be sinus tach, and it could be just compensating, agitated. So, and another part of the protocol is they got to be bleeding. So hemorrhaging with those vital signs, should kind of prevent some over triage.
Mm-hmm. Yeah.
I think so. Okay, we did a two-parter there, so we're moving right along. Now, we're taught the trauma triad of death in adults, now called the trauma tetrad, to include hypocalcemia. Do kids present with the same? Are they more or less vulnerable to that sort of hypothermia, acidosis, coagulopathy that adults are?
They are more susceptible for a couple of reasons. First, they overall have a higher metabolic demand already, so they already require more oxygen. And if they get hypoxic, they're more likely to go down the anaerobic pathway and produce lactic acid. Second, they typically have a higher surface area to like body mass ratio. And so with the bigger surface area, they lose more heat. So they're more prone to hypothermia. And then they have smaller blood volumes. So if you're giving them cold crystalloid or cold blood, then they cool down even more. And then the hypothermia affects your coagulopathy, and then you bleed more, and then you get, you have a higher metabolic demand when you bleed more, and so then you get more acid, and then the cycle continues.
Vicious cycle.
Yeah. So I think because of their baseline increased metabolic demand and their propensity for hypothermia, they're even more susceptible than adults to that.
That's really good to know. And it's good to know maybe be more deliberate in the managing the triad of death in kids. Be deliberate either way, but pay more attention to it in kids. We have full torso heating pads that we put on patients in trauma. We have vapor barriers that we can wrap them in. So I'd say definitely use that in kids. And we'll have inline warmers that will be placing the blood, running it through as well.
Yeah, and we're, if it's a bad trauma coming in, we should be heating our trauma base and keeping the doors closed and kicking people out so that we can close the doors right away, because and even the little ones, we have the French fry lights and all the stuff like that, because particularly the infants are very susceptible to hypothermia.
Yeah, we used to see that post-delivery before we had good warming mechanisms. They would come in hypothermic, and then we finally got the right heating pads and stuff like that. Now, something that I'm interested in hearing is injury mechanisms. Like, what common mechanisms of injury do you see pediatric patients come in that result in them requiring a large transfusion?
So, MVC certainly, anything that that puts them at risk of torso trauma. So seatbelt injuries, if you see a seatbelt sign, that is a huge red flag, and their belly's getting distended. Any of the pedestrian struck, kids being struck by cars, the bicycle accidents where they get the handlebar injury, they're more likely to have bowel injury, but not necessarily hemorrhagic shock.
Do you see bruising in them like you do with adults?
Yeah, a lot of times, for the handlebar injuries, you'll see a little, you can see some bruising, especially, a skinny kid that have thin abdominal walls, they'll get distended. So really, those would be the ones that their chest wall is also very compliant, and so they're much more likely to have underlying solid organ injuries or hemothorax, pneumothorax without actual bony rib fractures or things like that. So they may not have a chest wall deformity, but they could be bleeding, a ton.
Perfect. Okay, wonderful. Now, this one, I don't know. I think the jury may still be out on it. TXA is the standard of care for adults. We give it's like a performance metric in a lot of places. But what about for kids?
So there is a trial that we were supposed to be participating in, actually. It's called the TikTok trial. It got put on hold for COVID, and that reminds me I need to check on it. Everything got put on hold for COVID, and then they had to rewrite everything. But it's a prospective trial looking at TXA in kids. So there is at least one retrospective trial that I found out of Afghanistan looking at children, pediatric patients, and they found, just like in adults, a minority of the children got it, 10% of the children that they looked at actually got it, but there was an improved survival benefit and no increased like thromboembolic events with the TXA administration in that group. So that was a retrospective study, but there's not a lot of other studies. So I think if we can do this prospective trial, the TikTok trial, then that would help to answer the question. But at least retrospectively, it doesn't seem to cause harm and can improve survival. So in our massive transfusion protocol here, we have it listed as something to consider.
Okay.
The dosing is a little different. And interestingly, at Cincinnati Children's Hospital, which is obviously a leading hospital in the country, they have it in their MTP algorithm as well. So it's definitely safe, and I think can improve survival. So, that's something that if you guys are interested in it, we can give you our dosing information and stuff like that. Because I don't think that there's any known harm at this point.
That might be a protocol revision coming to you soon. So. Okay, so from a trauma surgery perspective, for adults, we practice permissive hypotension. Unless there's a TBI, if there's a TBI, we aim for like a higher systolic of around 110 to maintain that cerebral perfusion pressure. But is it different in kids, and what do you think is a good resuscitation strategy other than giving blood over crystalloids?
Yeah, permissive hypotension hasn't, in my knowledge at least, hasn't been something that's really reached the pediatric world. I think we certainly don't want to give them pressor and make them hypertensive, because that could certainly increase bleeding. But at this point, I think we worry a lot about decreased end organ perfusion for really any significant amount of time. And so aiming for normal tension or as close to that as you can get. And, there are different guidelines in general, greater than 70 plus their age times 2 would be like a normal systolic blood pressure for a child. And other than blood, instead of crystalloid, we try to avoid pressor, obviously. In trauma, you want to give blood and try to stop the bleeding. So if you can identify, just like you would in an adult, if there's a visible source of bleeding, a tourniquet on an extremity or holding pressure somewhere.
Don't just give blood and let them keep bleeding out.
Yeah. Obviously, there's not much you guys can do about intrathoracic or abdominal bleeding other than blood, and particularly whole blood, to try to give them factor and platelets they need to stop that. Those would, keeping them warm, obviously, like we talked about, would be the sort of the mainstays that I can think of.
And I mean, one of the main arguments for permissive hypotension is, well, if we give lots of crystalloids, we're diluting the clotting factors. It's often acidotic. We can pop the clot, but with blood, some of those main concerns are taken away.
Mm-hmm. Yeah.
And you gave the blood pressure 70 plus parentheses age times 2 for kind of estimate of what their blood pressure should be above. You can also look at the range, right? Like if you have a reference that has the normal range for the children, that's an acceptable method as well.
Yes. I think hypotension, it's less than 5, the less than 5th percentile of the normal range, maybe. But typically we'll think of it as, for an infant, like less than systolic of 60. And this, of course, is not counting preterms or neonates, which you guys they're probably still in the NICU.
Yep. Hopefully stay there.
I actually have a thing right here. Yeah, so for 1 to term neonates, less than 60 systolic. For infants, up to a year, less than 70. And then up to 10 years, less than 70 plus their age times 2.
Okay.
So, and then once they get greater than 10 years of age, the greater than 90 systolic blood pressure would be what you would be aiming for. And, we don't, in adults, sometimes you think about like a lot of people are baseline hypertensive. So what is their normal, and are they? But for kids, we don't really have that problem right now.
Yeah, that's a good point. Awesome. And I think we've already kind of talked about the clinical criteria determining when whole blood is needed for pediatric trauma patients. Do you have anything to add, or anything that we didn't ask that we should have asked, or any other pearls for us?
Well, no, I think it's great that you're working so hard to get this done. And I think try not to be afraid of kids. Like you said, they're not little adults, but in a sense, in the acute setting, they are. If they're bleeding, try to stop the bleeding and give blood. And you'll have your guidelines for how much to give. And then just knowing that, in particular, the highlights are they're way more sensitive to hypothermia, trying to keep them warm, and way less likely to get hypotensive. So you really need to be looking at those secondary signs like we talked about, the cold, clammy hands, hypoxia, respiratory rate, decreased pulses, things like that. I can't really think of anything else.
Okay. Well, this was awesome. Well, we really appreciate you taking the time. I know it's been hard to fit you in.
Yeah, sorry.
No, this was great. Thank you so much.
Thank you so much.